I'm going to talk to you about vasoactive drugs, and before everybody switches off and says that's not something I use, it's not going to be the fine-tuning of vasoactive drugs in the ICU that I'm going to be talking about. It's using them in the initial resuscitation and stabilization of the critically ill child before the retrieval team come out. So hopefully this is going to be something that's going to be relevant to most of you, because whether you like it or not, there is going to be situations where you are going to have to start these drugs. Let me just get my slides moving. So as I mentioned, I'm going to do this with a series of cases, and I'm going to be asking you guys to vote about what you think is the right option for each of these cases. So we're starting off with a 1-year-old girl. She's got group A strep, and she's currently got septic shock and being prepared for intubation. Her airway is patent. She's saturating nicely on 100% oxygen, a bit tachypneic at 55 breaths per minute, and she doesn't have the most pretty gas. pH is 7.12, and we've got a mixed respiratory and metabolic acidosis. And the gas is quite alarming. We've got a lactate as high as 11.1. We can see the reason for that when we come on to assess her cardiovascular system. Heart rate's all the way up at 195, cap refill is 6 seconds, and she's markedly hypotensive with a MAP of only 42. She's already had 40 mils per kilo of fluid resuscitation. She's only responsive to pain, and she's got a temperature of 39.2. So I want you to go over to Slido and vote for which of these options you think we should go with. So we're happy enough. We don't need to give her any more drugs at the moment. We can just go with fluid. We can put her on an adrenaline infusion, a milrinone infusion, a noradrenaline infusion, or use push dose adrenaline. And I'll give you a little bit of time to get your answers in. Okay, so I think most of you are going for the adrenaline infusion. So I'm going to come back to this question. I will go through a little bit more. So when I'm faced with a patient like this, there's a few things I'm going to ask myself. The first is, do I need to do anything with this patient's preload? So do I need to fill them with more fluid? Do I need to do something with their function? So do I need to improve the cardiac function? And do I need to do something with their afterload? So that's the vasculature. Most commonly, do we need to squeeze that a little bit? Or sometimes do we actually need to dilate that to improve flow to the organs? And you might be wondering which of these complex methods we're going to need to use to decide what we need to do with this patient. Well, you'll be pleased to hear the answer is, at least initially, none of them. Because we're going to start off, this patient is crashing, and there has to be a standard set of care that somebody can initialize without the specialist skills to do invasive monitoring, ultrasound, or different things like that. So we're going to manage this patient initially as per our APLS guidelines. So in terms of the preload, the safest thing to do is assume this patient is empty with their type of shock and fill them full of fluid. And you're going to stop when there's signs of fluid overload. So the guidelines would say you're going to give 40 mils per kilo of fluid. If they're still shocked, you're going to give another 20. This child's circulating volume is going to be 80 mils per kilo. So by giving them 3/4 of the circulating volume over a pretty quick amount of time, you can safely assume that you have filled this circulation up. In terms of the function, yes, it would be great to pop the echo probe on, and some of us may do that initially if we are there and we do have the skills to do that, but you don't need to. What you're going to do is assume this child has some myocardial dysfunction, and the vasoactive drugs that you're going to use are going to have to support the heart. In terms of afterload, again, you're going to go with the most common thing here, and that is to assume that you are going to have to squeeze the afterload a little bit and pick a drug and section of fluids that do all of that. The most important thing with this child is actually to stabilize them for intubation, because you're about to give this child an induction agent, which is highly likely to make them decompensate and arrest. And even if you resuscitate them absolutely perfectly, they are still likely to decompensate when you give them that induction agent. In terms of what we use for vasoactive drugs, I think all the guidelines are fairly clear. Adrenaline is our first line drug. We moved over from dopamine a number of years ago, although the evidence for doing so is actually quite weak. But that is what the recommendations are. Adrenaline tends to be the first line drug that we go for. So let's take a look at adrenaline. Now, if somebody's to put this slide up in a talk I was looking at, I would immediately switch off. It's got lots of receptors, doses, half-life. Don't do this. All the stuff on this slide is really, really important. It's going to help you when you have one of these patients, and it's certainly going to help you for the next lot of cases that we're going to come on to. So bear with me for a couple of minutes while we go through it. So adrenaline works on your adrenergic receptors. We've got alpha and beta receptors. The alpha receptors are the ones that squeeze the vasculature and increase your systemic vascular resistance. The beta-1 receptors are the ones that increase your heart rate and increase your ventricular contractility, whereas your beta-2 receptors, they will actually cause a little bit of peripheral vasodilatation. Although in all but very low doses of adrenaline, we're not going to see this because the alpha effects are stronger and they'll cause the vasoconstriction. And don't forget, due to its beta-2 receptor effects, adrenaline will cause bronchodilation. So we do have a difficult to manage asthmatic. Putting them on an adrenaline infusion for that is actually quite helpful. In terms of the dosing range, it will vary depending on the regime you look at, but it's somewhere between 0.01 and 1.5 mics per kilo per minute. In the lower doses, the beta effects are going to predominate. So you're going to increase your heart rate, increase your inotropy, and cause potentially a little bit of vasodilatation or do nothing to your afterload at those lower doses. By the time you're getting up to about 0.1 mics per kilo per minute, you're starting to get the alpha effects predominating, which are going to cause your vasoconstriction. You're still going to have those beta effects, and they will increase as the dose goes up. But this is the dose you're going to want to start for our patient with septic shock, and that's what the guidelines recommend. And the reason for that is because this is the dose that you're starting to get a squeeze in the afterload, which is what the majority of these patients are going to need initially. In terms of adrenaline, it works very quickly when you start it. It has a very short half-life, around about 2 to 3 minutes. So you need to have a really secure line, because if you lose your line, you're going to lose the effects really quickly. And if you're changing it from one line to the other, you can't simply take it off and move it over, because even that short duration where the patient isn't getting the adrenaline could cause the blood pressure to plummet. You're going to need to double pump it over. In terms of the special effects, we've already mentioned asthma is one place where it might be particularly useful, and anaphylaxis is another situation where you're going to find adrenaline particularly useful. Situations I don't really like using adrenaline, particularly high doses as a depressor. I'm not a big fan of it in older children. The reason for that, I find it causes quite a marked lactic acidosis, and that lactic acidosis is not due to an oxygen delivery problem. So adrenaline causes breakdown of glycogen, which makes pyruvate, which makes lactate. And older children just seem to have this more often. And the problem is in septic shock, we're using our lactate clearance as a marker that our patient is getting better. So if actually we're treating our patient and their lactate goes up, the first thing you think is that treatment actually working? And you might falsely move away from a treatment that's working because your lactate is increasing. So I don't mind using it in older patients as an initial drug to get them resuscitated. But later on, I won't be happy leaving them on high-dose adrenaline as a suppressor because I think it can cloud the picture. So how do we give adrenaline? So we're going to give it, one method is by infusion, and this can go centrally or peripherally. You've got the methods up on the screen that I use to make it up. It will vary a bit from region to region. So centrally, 0.3 milligrams per kilogram and 50 mils. You run it at 1 mil an hour, and that gives you your 0.1 mics per kilo per minute. To make it up peripherally, it's 1 milligram of adrenaline, 50 mils of saline, 0.3 times the patient's weight. So for a 3 kilo child, 0.9 mils an hour, a 10 kilo child, 3 mils an hour, and that gives you your normal starting dose of 0.1 mics per kilo per minute. The biggest thing when starting adrenaline is to factor in your dead space. So you can see here this cannula and connector, the total dead space is 0.4 mils. If we were to start a peripheral adrenaline infusion on a 3 kilo child, it would actually take 27 minutes to get through the 0.4 mils of dead space, which is really alarming. So if you were starting this thinking you're treating your patient and you haven't factored the dead space in, you're not for almost half an hour in a small baby. So you need to know the dead space of the connectors that you're using in your department. You can just put a syringe with saline onto it, flush it through with a 1 mil syringe and see how long it takes to come out the end. And then you save that number away. So the next time you're starting a critical drug on your patient, you can bolus that volume through the dead space and the drug is going to reach the patient without any delay. Another way to do adrenaline, and it was one of the options, was push dose adrenaline. So to do this, you take 1 mil of your rest dose adrenaline, 1 in 10,000, and dilute it by a factor of 10 by adding 9 mils of saline to it. So that's going to make you adrenaline 1 in 100,000 or 10 mics per mil. In terms of dosing, it's the same volume that you would give a child in a cardiac arrest, so 0.1 mils per kilo. But because you've already diluted it by a factor of 10, you're given a tenth of the dose that you would in a cardiac arrest. Another important thing to remember, if I had an adult who was I needed to give this to, I would give them 1 to 2 mils at a time. So for anybody who's 20 kilos and above, you tend to cap out at a max of 2 mils at a time, and that works fairly well. So let's go back to our patient and see what we need to do with them. So in terms of, we've already decided adrenaline is the treatment of choice. We're going to give them some more fluid, fill the circulation up. And in terms of the regime for adrenaline, we could either give them an adrenaline infusion starting at 0.1 mics per kilo per minute, or we can give them some push-dose adrenaline. And when I'm trying to decide between the two, the question I ask myself is, do I have time to make up this adrenaline infusion, to get it connected up to the patient through the dead space, and then titrate it to effect without the patient arresting? If the answer is yes, then I'll go with the adrenaline infusion, because it gives you smoother control of your blood pressure. With the push-dose adrenaline, you get big swings where it goes up, and then you have to watch very closely and it'll fall away again, and you need to give another bolus. So adrenaline infusion would be the preferred choice if you have time. If you don't, I would go with push-dose adrenaline. So I would look at this patient and I would see that they have a lactate of 11, they're only responsive to pain, and they are hypotensive, which we know is a peri-arrest sign. And I would say it's not safe to prepare an adrenaline infusion. The time it takes is too long. I would give them a push-dose adrenaline. I would monitor them closely and repeat that as we need to, get them up on an adrenaline infusion, and then titrate that to effect. Even if we did have time to get the adrenaline infusion up in this patient and we were getting them ready for intubation, I would still expect them to decompensate on intubation, and I would have push-dose adrenaline prepared as well, because that's highly likely to happen. Okay, let's go on to case number 2. So this time we've got a 12-year-old with acute lymphoblastic leukemia and neutropenic sepsis. So their airway is currently patent. They are a little bit tachypneic, 21 breaths per minute, but they are parexic at over 40, so that's not a big surprise. They're saturating at 100% in air. They've had a gas done, which shows an elevated lactate of 4.5, and because this has come from a central line, we've also got central venous oxygenation saturations. They are low at 52%. If you're not familiar with these, generally if your blood goes at 100% saturated, when you sample it from a central line, there can be allowed up to 30% extraction of oxygen, so your sat should be at least 70% saturated. If it's more than this, it would point out that you have a problem getting oxygen to your tissues, and the common reason in septic shock is there's just poor perfusion to those tissues. So it's an early warning sign that this patient might not be perfusing their organs particularly well. We can see the reason for this when we come on to the cardiovascular system. We are hypotensive with a MAP of only 48, but when we look at the blood pressure, the thing that I'm noticing is the diastolic is quite low compared to the systolic. Normally it would be about half the systolic. So we've got a widened pulse pressure, and we've got other signs of warm shock here with flash cap refill time, bounding pulses, and warm peripheries. So we've already given 40 mils per kilo of fluid resuscitation. And then we need to decide what we're going to do next. So I'll put the options up on the screen. So if you want to go over to Slido and vote, and the options are exactly the same as what I gave you the last time. Okay, so I think most of you are going for noradrenaline here. So when we look at this patient, we have to decide what we want to do with their circulation. So as I've mentioned, the most alarming thing here is that our circulation is too dilated, and we want to squeeze that down. In terms of filling, the other thing, our circulation is a bit empty, but the reason for that is it's because it's too dilated. We could, of course, fill that dilated space with more fluid, and that would temporize things. It doesn't solve the underlying problem, and that fluid is going to leak out into the tissues and cause more problems later on. So the ideal way is actually to squeeze things down rather than putting more fluid in. In terms of cardiac function, we may or may not need to augment this child's function, but we have time here. This is not a crashing child. And as I've mentioned, older children, I'm not a big fan of using adrenaline unless I have to. Crashing child, no problem. This kid isn't crashing, so we do have other options. They're not going to appreciate you making their heart beat much faster than what it's doing and giving them palpitations, putting their blood glucose up, and actually potentially causing that lactate to rise further. So my preferred choice for this child would be, I would agree with you, I would go with a noradrenaline infusion. And particularly as we've got the central line there, it would be fairly simple to put up. I would then put the echo probe on and see what's happening with the heart function. If it was impaired, we could add in some low-dose adrenaline. But even if I didn't have the ability to put the echo probe on, we could look for lactate clearance, improvement in blood pressure as signs that things are improving on the noradrenaline. And if they weren't, and we didn't have the ability to do an echo, then we could start some low-dose adrenaline to cover for potential myocardial dysfunction. So let's take a look at noradrenaline. So again, it works on the adrenergic receptors, alpha and beta receptors, but it has more of a predominance for the alpha receptors. So it is going to give you more vasoconstriction per dose than what adrenaline will do, and less beta effects. So it doesn't have beta 2 receptor effects, but it does have beta 1, which will increase your heart rate and ventricular contractility. I'm not a big believer that it has an awful lot of beta 1 effect. Generally, when I started, I find that the heart rate actually slows rather than it increases as a reflex due to the vasoconstriction that you get. And I wouldn't be relying on it to improve ventricular function in a child that I know the function significantly impaired. And there is other mechanisms by raising the blood pressure where the function will improve. It's going to improve preload by squeezing the venous circulation. And also by improving blood pressure, it improves your coronary perfusion pressure, which should improve your ventricular contractility as well. Dosing is very similar to adrenaline, 0.02 to 1 mics per kilo per minute. Again, we're starting at about 0.1 mics per kilo per minute. Similar onset and a half-life around about 2.5 minutes. So again, you have to be careful when you're moving it from one line to the other, and you need a secure line. Okay, moving on to case number 3. This time we've got an 8-year-old who has had an out-of-hospital cardiac arrest lasting 20 minutes. You've just got ROSC in the emergency department. Your patient is intubated. They're being ventilated at 20 breaths per minute and saturating nicely on 100% oxygen. Gas isn't great, but it is improving from the one that you've got during the arrest. Perfusion, 4 seconds, but again, improving minute by minute. And you've got a blood pressure by the map of 70. During the cardiac arrest, you've given 40 mils per kilo of fluid resuscitation and 5 doses of adrenaline, 10 mics per kilo per dose, given every 4 minutes or every other cycle. Pupils are unresponsive, pupils are sluggish, conscious levels unresponsive, and the patient's a little cool at 35.8. So again, what treatment do you want to do? We've got the options: no vasoactive drugs, adrenaline infusion, milrinone infusion, noradrenaline infusion of 2 different doses. Okay, so I think adrenaline infusion is winning just about with no vasoactive drugs as the second option. So before we come on to our goals, I think the first thing you have to realize with this patient is they are on the equivalent of a massive dose of an adrenaline infusion, even though they're not connected up to a pump. During the cardiac arrest, they've been getting 10 mics per kilo every 4 minutes, which equates to 2.5 mics per kilo per minute over the last 20 minutes. Remember I told you the dose for septic shock, we're going to start at 0.1 mics per kilo per minute. So for the last 20 minutes, this child has had an absolutely whopping dose of adrenaline. They've had 25 times the dose of adrenaline that you would give to a child with septic shock for 20 minutes. Now, I have told you the half-life of adrenaline is quite short, but with that amount of adrenaline in the system, it is going to be gradually decreasing down. But when you do your first assessment in this patient after you've got ROSC, they are on the equivalent of a massive dose of adrenaline, and that's what you have to factor in. My goal with this patient is to prevent them from re-arresting. And there's 2 things you can do. You can gamble that this patient is going to be safe to let that adrenaline wear off, and we'll see what happens. I think this is a terrible idea. And actually, if you've seen patients, you've got ROSC and they've arrested again 20, 30 minutes later, this is probably the reason why. You got ROSC, everything looked okay because they were on a massive dose of adrenaline. You let that wear off, and then they weren't okay. And the reason they might not be okay is after a long cardiac arrest, you're highly likely to get some myocardial stunning. So that is where you get significantly impaired cardiac function. It can occur immediately after arrest or up to 7-8 hours later, and it lasts somewhere between about 24 and 72 hours. So my patient is likely to get this. I'm not happy at all to see what happens. The patient may be in the CT scanner on the way up when the adrenaline wears off. They might be in the ICU but not have your invasive lines in yet. And I think the safest thing to do is put them on the adrenaline infusion. I normally start about 0.1 mics per kilo per minute and titrate it to effect. And it's only when they're in an ICU with their invasive lines, when we put the echo probe on, that we'll even consider weaning that off. In terms of neuroprotection, this patient has had a long arrest. Their brain is likely to swell up, and we're going to be wanting to target higher than normal blood pressures. So another reason why you're going to need some vasoactive drug support. Okay, case number 4. So this time we've got a 3-year-old with an isolated traumatic brain injury. There is some bleeding in the brain that the neurosurgeons need to evacuate urgently, and they've advised you to transfer this child without delay to the tertiary centre, straight to theatre, where they're waiting for this child. They're currently intubated. They've got been ventilated along at 25 breaths per minute and saturating nicely in 100% oxygen. Gas is good. The CO2 is at the low end of normal, just where we want it. In terms of the cardiovascular system, they are a little bit bradycardic at 75, but we've got an appropriate blood pressure per age, and they have a 20 mils per kilo of fluid resuscitation. They're unresponsive, they've got a blown right pupil, and they're normothermic. So again, go over to Slido and vote for which of the treatments you think we should go for. So no vasoactive drugs, adrenaline, milrinone, noradrenaline, or vasopressin. Okay, so it's fairly similar to the last time, a race between no vasoactive drugs and adrenaline infusion, but with no vasoactive drugs seems to be the winner. So my goals for this patient, number one goal that takes precedence over everything else is getting this child as quickly as possible into the hands of the neurosurgeon. So anything that is going to delay that is not going to be good and not going to be in this child's best interest. So in terms of putting central lines in, arterial lines in, anything that's going to delay the transfer is not something that we're going to be doing. In terms of starting them on a drug for blood pressure, we do actually want to raise this child's blood pressure. It is normal for age, but we actually want it to be slightly higher than normal. There's significant mass effect in the brain, and we're not going to be perfusing the brain particularly well. We do have age-related targets, and if we look up this child's age, we're going to want a cerebral perfusion pressure around about 50 millimeters of mercury. We don't know the child's ICP, but we can assume it's elevated, probably at least 20. So we're going to want our MAP to be at least 70. The other thing you can do is you can just target the higher percentile for this child's age, and that will give you a similar number of a MAP of about 70. So we are going to want to raise this child's blood pressure. Now, in terms of doing it, we could do it with fluid. Not the best approach because we're unlikely to get it up above normal without significantly overloading this patient. And in terms of doing that, that's not going to be great for their head. It's going to increase the risk of cerebral edema. So we do need to use drugs. The two drugs we can use are adrenaline and noradrenaline, and both those can be given peripherally. The acceptance that noradrenaline can be given peripherally is probably lower. I've only used it a handful of times in my career, and certainly adrenaline is something that most people are familiar with. And it would be the drug I would recommend for this situation, mostly from a human factors point of view. I would worry if I advised the District General Hospital to start this patient on peripheral noradrenaline. The anaesthetist might not be happy to do that. They might decide they're going to put a central line in to give that noradrenaline that PIC are asking for, and that will delay this child's transfer. At the very least, it's going to cause a bit of confusion, a bit of discussion, maybe another phone call back. Are you sure you want me to do this? And that's not going to be the best thing for this child. If I say start them on a peripheral adrenaline infusion, the District General Hospitals are pretty happy with that. They do it on a regular basis for septic patients. They'll do that and the child will be out the door very quickly. And that is purely from a human factors point of view. This is what I would recommend. Had this child been in my ICU with a central line in, I would be starting them on noradrenaline. And the reason is I don't want to do anything to their function. All I want to do is squeeze their afterload and raise their blood pressure to perfuse their potentially tight brain. Okay, last case then. So this time we've got a 5-day-old baby with suspected duct-dependent congenital heart disease. We haven't had an echo done, so we're not sure of the exact lesion. Our patient has started having apnea since we've put them on prostaglandin, and they're being intubated for transfer to the tertiary centre. So their airway is currently patent. They are breathing at 75 per minute, so a bit tachypneic with quite frequent apneas in between. They're saturating at 79% and 30% oxygen, and that has been reduced down from 100% on PIC's advice, and it hasn't made any difference to the saturations. In terms of our gas, it's not great. Our lactate is elevated at 6.1. We're a bit tacky at 180, cap refill of 3 seconds. And in terms of blood pressure, we've got a MAP of 45. We've already had 30 mils per kilo of fluid resuscitation. We've got dinoprostin running at 20 nanograms per kilo per minute, and PIC have advised increasing that up to 50, given the elevated lactate and concerns that this duct is closed or closing. We're only responsive to voice and where our temperature is normal. So go over to Slido again and vote for the option you think we should go for. We've got very similar options to the last time. No vasoactive drugs, adrenaline infusion, milrinone infusion, or push-dose adrenaline. And we've got 2 different doses of the adrenaline infusion. Okay, so no vasoactive drug seems to be the most common. Milrinone is coming up as a close second, so I will touch on that at the end because I think that might be potentially quite a dangerous choice for this particular patient. So what are our goals for intubating this patient? The biggest thing is stability. This child has likely duct-dependent congenital heart disease. So their myocardial function might be impaired related to the condition that they have, which we don't know exactly what it is. They're not in the best state though. Their duct is closed or closing, and their lactate is elevated. So for any child like that, intubating them and giving them an induction agent, they may not tolerate it well. So we are very definitely going to want to support their myocardial function during this intubation. So no drugs wouldn't be the best approach. In terms of their preload, they've already had 30 mils per kilo of fluid. They've got an adequate blood pressure. We probably don't want to put any more fluid in. In terms of the afterload, we've got a MAP of 45 in a newborn baby, which is perfectly adequate, so we don't need to squeeze that anymore. Really, all I want to do with this patient is support their heart during that period of going off to sleep. You might argue, actually, the blood pressure is okay. Shall we not just see what happens, and if they deteriorate, give them push-dose adrenaline? The downside of push-dose adrenaline is it's a massive dose of adrenaline. You're giving 1 mic per kilo, which is 10 minutes of a standard sepsis dose adrenaline infusion given instantly. And what that is going to do, we've looked at the receptors and what it does, it's going to cause massive afterload increase. So the heart is going to suddenly have to eject against a massive increase in resistance. And if the heart function's impaired, the baby may well not enjoy that. So if this patient was crashing in front of me, of course, I would have no problem giving that push-dose adrenaline. This is a great way to keep the child alive. It's going to massively improve their function and increase their heart rate and prevent them potentially from arresting. But it wouldn't be my preferred way of supporting the heart. I would much rather do that with an adrenaline infusion that's in before we give the induction agent. So we've got inotropy in before we start, because in general, prevention is better than cure. And then we'll have options to gently turn that infusion up should we need to, rather than giving a big slug of push-dose adrenaline, which we're going to reserve for that severe emergency that doesn't respond to increasing the adrenaline infusion. Now, milrinone was mentioned as a choice. The problem with milrinone is it's got quite a slow onset. So you're going to start it, it's going to take a very long time before it actually works. If you look in the BNF, now nobody's ever going to do this. It mentions giving a loading dose because it takes so long before it works. If you give a loading dose, the blood pressure will absolutely bottom out, and nobody ever does it, despite if you look in the BNF, though it does recommend it. The other problem with milrinone in this particular situation is it has a long half-life. It's about 45 minutes. So if you give this drug and it drops the blood pressure, you're stuck with it. It's not going to go. You can stop it, you can disconnect it, you can dangle the infusion in the air, but this drug is still going to be in this child's circulation for a very long time. So milrinone might be something safer to add in at a later stage, but for the initial resuscitation and covering the intubation of this child, one, is not going to work because it takes too long to act, and two, when it does act, it's going to act for a very long time. You don't have invasive lines in. It's not going to be the right drug for this particular patient. Okay, so summing up, what I think are my key learning points with vasoactive drugs. In terms of look at your patient, decide what you want to do. What do you want to do to their preload? What do you want to do to their function? And what do you want to do to their afterload? And pick a drug or collection of drugs to achieve all those effects. Remember, your patient's empty. The drugs aren't going to work, so you may have to fill them up. In most situations, you're trying to return preload function and afterload to normal. When I was a registrar, I could not understand why we put patients on vasopressors. What they do is they squeeze the afterload down, so it limits the blood flow to the organs. It makes the heart eject against more resistance. And by doing that, the heart has to work harder, use more oxygen. I could not understand why we did this. The reason is you're not actually trying to do this. You're only going to use a vasopressor for a circulation that's too dilated. You're going to squeeze it back to normal, but you're going to stop here. You're not going to keep going where you squeeze it down further and limit flow to the organs. In terms of the function, you're going to take a heart that's not beating effectively and make it beat effectively, but you're not going to keep going till that heart is tachycardic and hyperdynamic. So you're just going to titrate the drugs to effect. And in terms of filling, it goes without saying that you're going to fill the patient to euvolemia, and you're not going to keep going until they're overloaded. Remember that doing too much can actually do more harm. So if you actually squeeze too hard, you're limiting the flow to the tissue. So don't just keep turning the drugs up if things aren't getting better. Go back and assess your patient and decide what you need to do to each of those systems. If you have squeezed too hard, don't just add in something to dilate the system. Think about, can you actually reduce something first of all? So if you're on a pressor, reduce the pressor down first before adding in a vasodilator. The difficulty comes if you're on a drug that is providing ionotropy and vasoconstriction, and that's why I'm a big believer in using different agents. So I'll start adrenaline, use it up to high dose for the initial resuscitation, but when the patient gets to the ICU, I'll start them on some noradrenaline, and I'll wean that adrenaline back to an inotropic dose. I'll keep my pressors and my inotropic drugs separately, and that just allows me finer control. In terms of other things, don't forget about your calcium. All these drugs need calcium to work. They work by increasing intracellular calcium. So your ionized calcium on your blood gas is less than 1. Give some calcium and you'll find your drugs suddenly start working. And if you're on 2 or more of these agents and they're not working, this is the time we think about adding in some low-dose hydrocortisone for relative adrenal insufficiency. So I'll put the feedback code up for this particular talk. So you're going to need to enter this in when you're doing your feedback to get your certificate for this talk. And if there's any questions, I'll take them now.